Good morning, everyone. Welcome to the... So thrilled to see everyone. Packed house, makes me super happy. Such an important topic. Welcome to the National Press Club. I'm Alice McCown. I am the publisher of The Atlantic, and we are here for a forum on elevating the future of women's health. We're so pleased to partner with Medtronic and Women as One and Women Heart to raise awareness and urgency around women's heart health. We all know that heart disease is the leading cause of death in women, but the question is, what are we going to do about it? Women's health is no longer an issue reserved for the doctor's office. It's a source of debate amongst lawmakers all across the country and is being legislated in the courts. Today, we have clinicians, researchers, patients, and advocates here to provide you with data-driven solutions meant to save lives. So many of you in the audience are steeped in this work. We hope this is a space for collaboration where you will learn something new to implement in your practice and better inform your advocacy. Now, I would like to invite to the stage Nina Goodhart, President of Structural Heart and Aortic at Medtronic, who will share why we are at a real crossroads in women's heart health.
Thank you. Thank you. We are supported here by Women Heart, which is a nonprofit here based in Washington, D.C., really focused on educating women, creating awareness about cardiovascular disease, and supporting women on that journey. We're also supported by Women as One, which is a global nonprofit focused on empowering women in cardiology and making sure that we bring more women into this critical specialty when it comes to health and women's health. We have been talking about women's health for decades. It is somewhat shocking to me, to be honest, that in 2024, we still have to advocate for women's health and women's heart health. So much has happened over the last several decades. You can see here on the slide, you can get a copy of this, but starting in the 1970s, when after the thalidomide crisis, the FDA mandated that women of childbearing years could not be included in clinical trials, right? Fast forward into the late 1980s when that was finally lifted, but we still don't see a predominance of women in clinical trials. And it's hard to treat people when you haven't studied them. And so we absolutely need to bring more women into research so that we understand finally that women are not just small men, right? I think we've all figured that out. Thank you for that. There have been organizations that have been doing amazing work in the early 2000s. The American Heart Association launched the Go Red campaign, the Red Dress campaign, and we started to see some really significant progress in mortality rates coming down, education of women, women recognizing signs and symptoms of heart attacks, et cetera, things that happen differently in women than they do in men. But then as the decade progressed, we started to lose ground again. That awareness came down, mortality rates went up. We have to do better. We have to do better for women. And so that's really what this is all about. It's bringing this esteemed group together. We are at a pivotal junction, as Alice said, right? We've got investment from the government into women's health. We have more and more awareness and education around women and women's health. We have more female physicians focused on women's health. We have more male physicians, and that is so critically important. Women can't just talk to women, because then we're talking to ourselves, right? We've got to bring that whole community with us as we advance this cause. So we are very excited to be a part of this and very excited to start this conversation. We think we're at a pivotal moment to advance women's health, and we think that this is just the beginning. So with that, why don't we get started?
Thank you so much, everybody, for being here. My name is Christina Ruffini. I'm a journalist here in Washington. Until recently, I was a correspondent for CBS News. And today, of course, we're going to talk about women's health, women's heart health. We've got a great panel. I'm going to let them introduce themselves a little bit as we go down the line. But first, I want to start with Dr. Hayes and what we were just talking about, which is not only is there a disparity in women's health care, but historically, women are not believed when they are sick, when they go to their doctors. I've experienced this in my own life. We were all just talking about it in the green room. Almost every woman had the same experience. Why is this still happening? And can you give us some historical context?
So I'm a clinical cardiologist at Mayo Clinic in Rochester, Minnesota. And this is, I founded our Women's Heart Clinic back in 1998. And remember, that's before the 2000s when there was Go Red and Heart Truth. But what I was seeing is that women in my practice, when I would see men versus women, the tests that I used, the drugs that I gave them, they reacted differently. So this has been something that I've been talking about for a long time. So people ask me, why are we still talking about this 30 years later? And part of it is, like, we paid for it. We paid for the Framingham study that showed that women with chest pain, we didn't have to worry about them back in the 70s. In the 80s, we paid for 350,000 men to be screened for Mr. Fit. That was the amazing clinical trial that told us that treating lipids, smoking, and blood pressure saved lives. Women were not included. Then we get to the 90s, and it was almost after that the Women's Health Initiative looking at hormones. This continues. Now, part of the reason, like, think about that Framingham study. They took men and women with chest pain, and they determined that since women didn't have events, they must not be something we have to worry about.
Oh, sure, yeah.
Right? Right, but that was one of the things, in addition to the thalidomide, that women didn't need, because whatever we study in men, we can just apply it to women and it'll be fine.
Right, because as we just talked about, we're essentially smaller men.
Right.
Yeah.
Right.
No
We weigh a little less, have nothing else.
Some of us don't, but
but I think the other piece of observations, and this is across all areas of healthcare, reproductive healthcare, gallbladder surgery or whatever, women and people of color's pain is degraded and not believed. Women are not valued in this society enough that we take their word for it. And one example I give about the gaps is, so my area of research is studying a type of heart attack that is the #1 killer of women under the age of 40. Serious research did not start on this first publications until 2012. Now, there's been heart disease research, and do you think the #1 cause of heart attack in men under age 40 would have waited until just over a decade ago? It just wouldn't happen. And I think changing the paradigm of where we put our money and investment and how we believe women and help all of our colleagues in healthcare and society so we can move this forward.
But why does it matter? I mean, when I was reading up for this, is it true that even the mice are men?
Oh, yeah. So it wasn't until, so I remember, so I have a colleague, Dr. Virginia Miller. She's retired now at Mayo Clinic, but she was a basic science. She studied rat aortas, right? And put hormones on them, saw how they react. So she was doing women's health research in the lab. And she railed against the fact that she had to specify, and the vendors of these male rats, or the rats, wouldn't even tell her what the sex of the rats were, and that some literature was actually being published in peer-reviewed medical journals that had done a study entirely on estrogen on male rat aorta rings. And she was just aghast. It wasn't until 2014 that the federal government and the NIH said, you have to at least specify what the sex of the animal or the tissue is. Don't go out there, and male rats are cheaper. They don't unexpectedly have babies. They don't have hormonal shifts.
No comments.
It's cheaper and easier for research to do. And if you think about some of the decisions that have been made to not include women, it came down to money. Because if you're going to look at sex differences, that means you have to double the size of your sample size. That costs more for industry-funded research, that costs more for taxpayer-funded research. So the tide is pushing us against studying women, and we have to push back.
There's also this kind of knee-jerk reaction that you can get when you say, we want to launch a study on women. It immediately shrinks the number of people who are listening to you. And Dr. Moran, you've been able to reverse that a little bit with this SMART study, which is over 85% female participants, but you didn't launch the study saying we need 85% female participants. How did you do this, and can you explain why it matters? And tell us a little bit about your background.
Well, yeah, thanks. I'm an interventional cardiologist, one that does procedures like stents and valve interventions, and I also am I'm a clinical trialist running clinical trials, and I was very, very honored to lead one of the leaders of the SMART study, and I'm at Mount Sinai. And the SMART study was a study that was quite smart. And the smartness about it was that we Just like I'm a mother, and when my children were small and I didn't want them to have macaroni and cheese, I would mash up broccoli or butternut squash that looked like cheese, and I would put it into the macaroni and cheese.
To be fair, I still do that with my meals.
They wouldn't know. And so here's the smartness about the SMART trial. We looked at a condition, aortic stenosis, that happens quite, in a high prevalence. It's underdiagnosed, underrecognized, undertreated in women. While women live a little bit longer than men in terms of their ages, and so they have a higher prevalence of aortic stenosis, which is the aortic valve, the main valve, that then gets calcified and blocked up, and it's the major supplier of blood to the rest of the body. And so when that gets blocked up, you could die. And it really is a very, very important initiative. And now we have ability to care for these men and women with aortic stenosis using a transcatheter approach. In other words, not opening the chest, going through the leg, performing a procedure with lots and lots of data that shows it's just as good as surgery. So we wanted to study two of the most important and highly used commercial valves, and we wanted to have lots of women. So in a condition that is more prevalent in women, small annulus, now we're not small men, let's make sure we understand, there's actual data that shows that the way the biology of women developing aortic stenosis is completely different than men. Less calcification, different remodeling, all kinds of biological differences. And yet women have not been studied. And so choose a condition that's more prevalent in women, and guess what? Not 85%, 87%, almost 90% women. And for the first time ever, it took till 2024 to actually have a study that has answers for women. We have an answer. We're powered to answer a question in women. And that just makes me so happy.
But you also did this by saying you wanted to study these smaller valves, knowing that most of the people with the smaller valves would be women. So that was a way for you to get a big female sample size, but to do it in a nominally gender-neutral way, right?
Absolutely. And we really need to introduce this as a gender-neutral way, because look at this audience. Most of you are women. I look forward for the day that we come back here and most of this audience, or half, will be men. Because as soon as you put the word diversity, women, it just isn't cool enough. And so people don't want to be a part of it. And the fact of the matter is that if we're not a part of it, if we're not in it, we are never going to win it. Heart disease is killing women in an astonishing rate. And valvular heart disease, the disease of the aorta, is a really prevalent condition. And we now have an answer. With 90% women, we can go and say, we know what to do for women, how to choose for women, which valve for a woman will work better. And that is what is really, really astonishing.
I think what's amazing as well is this was study design that was designed to be inclusive. Many of the trials that were done that I was referring to, those old ones, they had exclusion criteria that maybe made sense, like a heart attack trial, and you couldn't be over age 65. That excluded women not because they were excluding women, because women on average have a heart attack later in life. So you got no women. 65 was arbitrary. This, by being really thoughtful, was able to include more women.
We were smart.
Sneaky, yeah.
You should call the study that. That would be a good name for it. But to your point, you can't make the policy or change the way patients are being treated a lot of times unless you have the data. So Dr. Gardner, you run a big health system out in the part of the country where I'm from. I'm from Colorado. You're out west where, you know, you have fewer mosquitoes. But can you explain to us what you saw in your data of how you were treating female and male patients and how you addressed it and how you fixed it?
Absolutely. So I'm part of Intermountain Health, and it's headquartered in Salt Lake City, Utah. But it covers about 8 to 9 states. So we also have headquarters in Denver and in Las Vegas as well. So we cover a huge population. I mean, we're talking about 1/5 of the country right now. It's a large portion. And what Intermountain does, we certainly participate in a lot of the trials that are going on, contemporary trials around the world. But what we pride ourselves in is how we innovate and the way that we deliver care to the populations. And so as part of this, we actually took a deep dive and looked at specifically people that were having heart attacks. So there's different types of heart attacks, and this is what kills the majority of people, men, women combined. And there are certain protocols when somebody has symptoms and they actually interact with the healthcare system. So, an ambulance or so, police officer or something like that, or an emergency room, where you initiate certain protocols, and those protocols are all throughout the country. They're fairly similar. They may have some subtle nuances and differences in different parts of the country, but it's essential to initiate these protocols to save lives. And not just save lives, but if you survive, to have a better quality of life. And seconds matter. I mean, we're talking about 10, 20 seconds can mean the difference between life and death for somebody. So as we pulled the data, we were able to find that it took us about twice as long to initiate these protocols for women than it did for men. This was at one of our biggest hospitals in Salt Lake City, Utah.
When you started the deep dive into this data, did you know that disparity was there? Did you go looking for it, or that was just something that showed up?
No, as you talk to most physicians, they would say, oh, well, I treat everyone in front of me the same, right? And they probably do for what's in front of them. It's really a system issue. It's a recognition and awareness problem that we found out. So what we did is we started to have an awareness campaign. We started to change the protocols. And we were able to close that gap to where they're almost the same at this point, which tells me that we can make an impact. Like, you can actually do something. And I look at, obviously I'm a man, once we hit puberty.
We let a couple of you on the panel who thought it would be good.
We snuck on, but no. We're far more boring once we hit puberty than women, right? Physiologically, there's just no question about it. The only time that we get change is during a basketball or football game, I guess. I don't know, but nonetheless, there's a significant difference. And this really kind of came head to me when my wife was asking me a question when she was pregnant, and I'm a heart doctor, and I didn't know how to answer it. And I'm like, geez, I spent 15 years studying and training and all this stuff, and I really can't answer my most beloved person on this planet. I can't answer the question for her. So it was quite of a striking thing, but I do believe that we can have an impact on this. We just need to do it. We need to attack this in the ways that it needs to be attacked.
The time is now, isn't it?
It is.
Enough is enough,
Enough is enough.
When you found this data and you realized there was this disparity in the protocol, and you went to administrators and physicians, how was their reaction? Was there any kind of knee-jerk pushback? Because I don't think most doctors want to think that they're treating people differently. Was there surprise? Was there resentment? Or were people receptive?
I think there's going to be a lot of surprise from a lot of people, because I think as physicians, you're kind of programmed to treat what's in front of you.
Yeah.
I mean, that's just the way that we are. Whether we know that we have a bias or not is a different story. And sometimes it's not a personal bias. It's a systems problem. It's because we haven't studied women that we're not detecting what needs to be detected early enough, or we're not listening intently enough. So we instituted a protocol where from here to here, if you have any symptoms, man or woman, that you trigger these protocols. Yeah. So door to EKG time, or first contact to EKG time, door to balloon time, and all of a sudden the gap from taking literally twice as long, which probably translates into a lot of deaths. I mean, that's the sad part of it, shrunk down to almost equal in just 1 year. And so it's very impactful. I think we can do some pretty amazing things if we just put our mind to it.
It's pretty cool. Dr. Ye, last but certainly not least, you're kind of on the policy end of things. So having heard all of this, can you tell us first of all a little bit about yourself and what you need to see, what federal policy needs to do to help address these issues, to support this research? And then if you could talk a little bit about the Women's Health Executive Order that was put into place and whether or not you think that will have an impact on any of this.
Great. Thank you. So I'm John Ye, and I'm from the NIH. And as opposed to the three cardiologists here, I am an obstetrician gynecologist. However, I feel entitled to sit here because my daughter, who's in medical school, wants to do pediatric cardiology.
Oh, perfect.
So let me start off by just talking a little bit about the executive order that was signed on March 18th this year by President Biden. And from the NIH point of view, and I'm in the Office of Research on Women's Health, from the ORWH's point of view, this is a major day in women's health research. And the executive order is the first time there has been a presidential order directed at women's health research. And the champion for this Women's Health Research Initiative is Dr. Jill Biden, the First Lady, and she works closely with the Gender Policy Council. And the chairman of this initiative is Dr. Carolyn Missouri, who has a long track record of pushing women's health research across the country. And the executive order has 4 main points. The first is it requires the government to integrate the data that's collected across the government on women's health research.
Were they not doing that?
No, and it's going to require work, a lot of work, but at the end of the day, it will allow, for example, the FDA to talk to the NIH, to the CDC, because there'll be common elements in the data that's collected. And the second major point about the executive order is that it mandates prioritization of federal investments in women's health research. And the third point is an emphasis on women's midlife health. And the fourth point is that it requires the Office of Management and Budget to do an assessment of the gaps that are necessary to lead to advances in women's health research. And a number of federal departments and agencies were named in this executive order: the Department of Defense, the VA, the Department of Agriculture, the EPA, the NSF, Health and Human Services, including the NIH, FDA, CDC, CMS, the Centers for Medicare and Medicaid, the CDC. So it's a very wide-ranging executive order. And at the NIH, these offices and institutes were also explicitly named to be part of this initiative. The Office of the Director, the Office of Research on Women's Health, the National Institute on Aging, the NHLBI.
So you think it'll make a difference? You think they're pulling enough agencies in and enough?
Absolutely. And so how will that translate into something of interest for people in this room, heart health? So first, it defines heart health into 3 subgroups. The first is the group of women who have conditions that are specific for women. And as an example, in a woman who has had a heart transplant, who is pregnant, she would qualify in that particular category of potential research area. A second area is aortic stenosis, conditions in which the majority of the patients with this condition are women. And the third is a coronary artery disease in which the manifestations may be different in women. And so for the 4 parts of the executive order then, how can that be translated into heart health for women? First, by having data harmonization across the different agencies, it allows data to be useful to a much larger audience. Second, by making more investments in heart health or women's health and heart health, you allow new data to be generated. And so for fiscal year 25, about $200 million will be allocated at the NIH for women's health research. And in the State of the Union address, President Biden said that the administration is hoping to invest $12 billion into women's health research. So there's a lot of work going on in the federal government because of this executive order. And certainly I think women's health, women's heart health will benefit as a result.
That sounds promising. Given everything we've just talked about, if it continues to go in a positive direction, in a few years, what are you hoping women's heart health looks like? What would be a good way that any of you think you could tell that this has improved and outcomes for women have improved in this space? Is it patients being believed? Is it more research funding? Is it you exporting your findings to other health systems? Is it more effective advocacy?
I'll start because as excited as I am for this, I've been in this space for a really long time, and we've had regulations and investments that have fallen by the wayside, and there's been no teeth in them because no one held people accountable for, enrolling women. And so I hold my breath a little bit. I'm more excited about this initiative because of the energy around it. But I think that we in this room need to hold those who are promising the moon that we at least, get into orbit.
But how do you do that? What does effective advocacy look like?
I think it is asking for, whether it's OMB or whoever, to say, who's monitoring these things that we want to do? All of it sounds great. We have already paid for all of this data that CDC and FDA and NIH has, and harmonizing it will be amazing. But then what are we going to do with it? Are we going to then invest in researchers who may be more data crunchers than clinicians to then come out with real answers that then I, as a clinician, can put into place? So what would be, and it probably won't be in 2 or 3 years, but where the level of evidence when I am prescribing a medication, when I am recommending a procedure, when I'm making a diagnosis or ordering a test, that I know what is the data on women who undergo this procedure. So I can talk to her about, well, this is the data that we have, and it's 98% men. You'll probably do about the same. Like, that's, that has been right in a number of cases. It has been so dead wrong in many others. And I think, so I'm holding my breath, and I'm very cautiously optimistic. I don't think this is going to make a sea change, nor do I think this is going to address the issue about women being believed. That is a societal issue.
So I'm with you, Sharon, but I'm more optimistic. It's the first time.
I'm older than you.
I'm more optimistic.
I'm not breaking up any fights here today.
But I'll say,
Generally a glass half full person, but I have just seen it.
I'll say that I know, because we've all been sort of damaged in some ways because we've been given promises that have never been realized. But I do agree that there's a lot of check boxes. Oh, we did this, look at us, vote for us. And that should not be the issue here. We need to think about it much deeper, much more intentional. And I believe for the first time there's real money in it, but it needs to be done in the really, really good way to fund research that's implementable to the society. That it isn't just for white women, that it is also for women of color and different ethnicity. We've been talking about diversity and inclusion, and it's never been realized. And those data need to be collected in an ethnic way to understand cultural differences amongst women that are living in this country. But also, I think, very importantly, I think for the very first time, we are seeing that this kind of funding it's a carrot and a stick kind of thing, will bring more men to the table because they love money, so they'll come in. The major health institutions will come to the table because the health systems, which are businesses, are also going to be very, very interested in the funding that will then give them higher class, higher clout in terms of ranking. These are the ways, the Mayo Clinic loves to be the #1 hospital in the world. And so what we need to do is to continue with the efforts, the unfortunate efforts that people are rewarded with a carrot and a stick. And that is sort of the way to make things happen in the society. And I believe for the first time, because there's real money in it with real intention, that we can make a difference. And we have to, because the slowing of the decline of morbidity and mortality, especially in young women, is daunting across the globe. And so we have to make a difference, and it will happen. We're going to make it happen.
Yeah, and I think more what needs to happen is more of what Intermountain's doing. We need to be examining our own practices, and that should be part of the regulations now, and that'll be pushed back by every single health system in the country. because it's extra work, it's extra, it costs money, but we all think we're doing a great job, right? And until we actually look and examine our practices.
We're not doing a great job.
No, individuals
Dr. Gardner,
are.
from a health system perspective, it was expensive to do this, and it did cost, I'm assuming, cost money to implement new protocols. But from a health system's business standpoint, other than altruism and ethics and wanting to make sure you're treating your patients the best of your ability, is there a business reason to do work like this? Like, does it benefit your business? We don't like to talk about healthcare as a business, but it is essentially. And is there a way to do this that also can be argued to all the things that we were talking about that actually?
Absolutely. Intermountain's a bit unique in the sense that we're about half risk-based contracting, which makes us a lot different than a lot of other institutions. So we have a lot more freedoms to do some unique things. So from our standpoint, absolutely. And I think whether you're in a fee-for-service or risk-based contract type of situation, you can do some pretty cool things with this, and you can make it work. You just need to think through it. Can I just offer one quick challenge to the training programs around the country? Why do we not have a women's heart fellowship?
Yeah, well,
Right now, we're trying to, one of our number one objectives at Intermountain is the women's heart program. And you're trying, it's almost like this side thing for most people, right? You've got somebody who's very passionate about it, but we need to bring it to the forefront. And if we had all the training programs have a dedicated women's heart program, I think it would actually be more impactful than the
you're
structural
so
heart
right.
program.
And this is exactly what I have actually put out there. We put a curriculum for a year, and I've actually shared this with Sharon, because she's had the very, very first real heart center program in the country. And we're all emulating to do exactly that. And I've put forth that we must train not just women, but men need to come into those fellowships. Unfortunately, right now when you say heart disease for women, the boys run away. They don't want to do that, because then that just pigeonholes them into like taking care of women. That's just not cool enough. We need to make it cool. We need to make it with a prize that comes with it, and an enhancement of how we care for women. And we need more, not only more women in cardiology, but women in leadership positions who help bring more women forward. We're going to be in a really difficult place if we don't have more women in the workforce. We're right now at 17% of cardiologists in the country are women. And you know something? 10 years down the line in their practice, they say enough is enough. They give up. There's a decline, and they just run away from cardiology because it's male-dominated, it's misogynistic, it's a very, very difficult place. Let me tell you, I've done it, been there, done that, and in interventional cardiology, it's much worse. That's why I founded Women as One. And to actually emulate more women to come into the field so we stop the leaking talent that is leaving the field of medicine in cardiology. If we don't have more women in cardiology, the health of women in the world will suffer. And so we need to work on that as well.
So I think the corollary of what Dr. Moran just said is that means 83% of patients, women patients, are being cared for by men. And so we need the men to move forward. And so we need to empower men and not make them feel excluded, right? I have colleagues who say, oh, I defer to you because like you're the expert. And my goal is, I was asked when we founded the Women's Heart Clinic in 1998, what is your goal for 10 years? I said, we don't need the clinic anymore. Obviously, my dream was not realized. But I think that is a big thing, is we all bring our brains and our wits, and the men who care for women, which is still the majority of physicians and cardiologists, is the only way we're going to move. Thank you, men.
Thank you, men on our panel. Thank you, male cardiologists. And thank you to our amazing women here and in the audience and around the world who are working on this issue. Thank you all for being with us. That's all the time we've got, but that was great. And thank you so much for, if I had better math skills, I would go into cardiology, but no one wants that from me. So hopefully younger women can fulfill this need in the industry. But thank you all so much.
I think so. So incredible, right? We, to the point of the panel, we have to do better. We have a groundswell, I think, right now with the funding that we're getting, with the stringent need, the strong need that we're articulating here. I think we have to do better. We can do better, and the panel's given us ways to be able to do that. It was shocking to me, my daughter's an OBGYN, and I asked her, what training do you get on women's heart health, given the fact that OBGYNs are often the primary caregiver for women? And she said, zero, none. I have no idea how to answer any of those questions. So we have to train, we have to broadly train physicians to take better care of women. By the time they get to a cardiologist, they need to understand that women are different, they need to be treated differently, they need to be studied differently. We have the opportunity now to do that. We're going to need everyone in this room, everybody that you know, everybody that our physicians know to continue to move this forward. So thank you very much. So we are going to move on to our second panel. And we have to remember, with everything that was just discussed here, what we have to always remember behind every story, behind every initiative, behind all of the funding and the clinical trials, there are patients. And every patient has a story. And we want to help to bring some of those stories to you, really to highlight the need that we've identified here and everything that we're talking about. Before we do that, we want to share a very short video with you, and then we'll introduce the next panel.
If I walk from here to the other room, I get tired, I give out of breath. I had to stop and rest in between.
No podía caminar. Me cansaba por completo y levantar cosas pesadas tampoco. Me sentía como mareada. Entonces, pues ya comencé a sentir esos estragos.
Yo, impotente de no saber qué es lo que pudiera resolver su problema. Buscábamos puertas y puertas para saber cuál podía ser su solución, porque unos decían un diagnóstico, otro diferentes, entonces realmente no sabes.
In Julia's case, the referral early on by her cardiologist, once he recognized what she needed, was critical. Had it been delayed or ignored for much longer, we may not be talking about the positive impact we had on her.
I said, well, I got to get some help. I got to do something because I ain't ready to leave here.
Yo lo que quería salvarme. Allá me van a dar vida, allá me voy. Tan sencillo. Digo, ya cuando está uno así, dices tú, pues. Es una realidad en la que estoy viviendo, en la cual pues yo recomiendo con los ojos cerrados.
I can walk, I can dance, I can cook, drive, basically do anything I want to do. I'm really looking forward to getting up, getting on me a plane, or a car, or a bus, or train, and just go, go, go. At 80 years old, I think I'm entitled to enjoy the rest of my life. Live life to the fullest every single day. That's what I do.
So I love that, living life to the fullest every single day. It's amazing to see. So up next, we have our panel, Quality of Life Restoration, the Life-Changing Impact of Early Diagnosis and Timely Intervention in Women. And so joining us here today, please welcome Darian Times. Thank you so much for being with us, and it's great to see you feeling so well. Our patient advocate, author and founder of heartvalvesurgery.com, Adam Pick, thank you for being here. And CEO of Women Heart, one of the sponsors and our partners in this effort, Selena Gore. So I'll take it off.
Thank you so much, Nina, and thank you to Medtronic and to the Atlantic for hosting this really important event. In the patient community, we have a saying, nothing about us without us. And I think this event really embodies that. So I think, speaking on behalf of the patients on this panel, we're really thrilled to be here. Before I go on to my program, I want to say a special thank you to Dr. Sharon Hayes, who probably isn't in the room. But Dr. Hayes, in addition to all the wonderful things that she does, she has been the medical director of Women Hearts training, our Science and Leadership Symposium, since the very beginning. So she's a really special person to us, and a special person, as you heard this morning, to the women in heart disease community. As a heart patient myself, I really joined Dr. Moran's joy in celebrating this trial. And I want us to see this not just as a standalone trial, but really, hopefully, the beginning of a revolution. That we are teaching the community of those interested in innovating in the cardiovascular space that A, not only is it necessary, but it's possible. I'm sure many of you have heard excuses. It's difficult. We can't get women in trials. You know, this trial blows all of those myths out of the water. So again, I'm just really happy to be celebrating that as well. I'm going to ask all of you a question. How many of you have ever been a patient?
Yes.
So we're among friends, right? There's no separation between us up here and you down there. And that is what we hope to do today, is bring you all into this conversation. I want to start with Ms. Darian. You know, I know that in the beginning of the video you talked about your quality of life was really low, was really poor. And so I want to understand a little bit what you felt when you realized that there might be a way out, some relief, a solution to the problems you were facing.
Well, at first, I were on my way out. I was weak. When I say weak, I was weak. I didn't have no energy. I couldn't really do anything for myself. My kids had to come over every morning, give me a shower, fix my breakfast, get me dressed, put me back to bed, take me outside, sit on the porch for a few minutes. Then I was back in the house in a recliner. I didn't have no energy, no nothing. So I said, well, y'all put me in a nursing home. Go ahead and live y'all life and leave me alone.
But somebody came to you and said, we can do something about this.
Yeah.
So what was your feeling at that moment?
No energy, no nothing.
Yeah.
I was ready to give up.
And then did you see a doctor, and the doctor said, hey, there's something we can fix?
The cardiologist that I was seeing in Montgomery, at Montgomery East, he called me one day, asked me how was I feeling. I said, well, I don't know. He said, do you have a problem with going to Birmingham? I said, for what? He said, well, they got better doctors up there. They specialize in this every day. This is all they do. And I want you to go up there. I said, well, if you say so, I'll go. And that's how I ended up going to Birmingham. The doctor in Montgomery sent me up there to UAB.
And now you can dance. And now you can dance.
Who am I? Am I?
Adam, I know in conversation I understand that your experience was quite harrowing as well, that you talked about getting lost in the system, and that there was a night that you were actually out having dinner and you knew you had to go to the doctor. Can you talk a little bit more about that moment?
Yeah, so my name is Adam Pick. It's nice to meet all of you. And I want to let you know it's a total fluke that I'm here right now. I'll explain why. My background is all technology, working or consulting for companies like Dell or Hewlett-Packard. And to answer your question, one night I was out to dinner at a Mexican restaurant with my wife, Robin, and I reached to get a tortilla chip and put some salsa on it. And in that moment, the left side of my body went numb. And within 30 seconds, we are on our way to the car to go to the hospital. Got in the car, the numbness stopped. My wife looks at me and she goes, do you think it's your heart? And so, you know, I was born with a congenital heart defect known as a bicuspid aortic valve that progressed into this thing, this nasty thing, this deadly thing called aortic stenosis. And so the situation was one where I go get an echocardiogram because that's the gold standard for diagnosing aortic stenosis. And Dr. Bad Bedside Manner walks in to the consulting room. He opens up this is no joke. He opens up the folder, looks at my tests, and he says, you need open heart surgery. You need it really soon. Do you have any questions? And so then pure chaos, right? You talk about being lost. It's chaos. On the front end of the system, I didn't know who to trust. I know which procedure to get, what doctor, what hospital. And then on the back end, I get this great surgical result. But then you know what happens? I get impacted by a Vicodin addiction because of pain management problems. And then I go into full-blown cardiac depression. They don't tell you those things all the time, right? When you're getting ready for these big procedures. And so I got lost on the diagnosis. I got lost in the recovery, and I ended up in therapy, okay? And I said to my therapist one day when I was like bawling, it was all coming out, I said, why doesn't someone do something to help patients? Take a guess what this brilliant woman said to me.
Go to therapy.
Why don't you? And with $199, that's when I started heartvalvesurgery.com.
Awesome.
Yeah.
Awesome. So it's interesting, I'm listening to you say within 30 seconds you were at that restaurant and on your way. My experience as a heart patient was that I had a lot of self-doubt. You know, I had symptoms, but I brushed it away. I think many women do this. I eventually got to a diagnosis after 9 visits to the ER over the course of 2 years. This was after, I had been the CEO of Women Heart at this point for 3 years. So look, if I don't know something about women and heart disease, right? And I still had all of these barriers. Some of them were self-imposed, like I said, you know, so many doubts about what was happening to me. But once women show up to the ER, they've already gone through those steps of, oh, it's just, I'm fatigued, I'm stressed, you know, it's been a long day. So if you show up to the ER and you're not believed, as we heard this morning, right, what's your next option? That's supposed to be the option of last resort, and yet we are sending women away from that option of last resort on a regular basis. This is not uncommon. So, you know, I think doctors like to think about my experience as a one-off. But just about every single woman heart champion that has come through our doors and that Dr. Sharon Hayes has trained has a similar story of not being believed, of delays in diagnosis. We heard that, you know, we're underdiagnosed, we're undertreated, and we have worse outcomes, and we're underbelieved. Let's add that to the list, because that is also a really key factor. You know, Dr. Moran mentioned this morning that women have longer life expectancies, and I think that is used as a crutch by the healthcare system to say, what are y'all complaining about? You live longer, but we also live sicker. We live longer, sicker, and that is what we're talking about as well today. So let's get back to Adam. You, as you just mentioned, created heartvalvesurgery.com, which is a fantastic resource. And tell me how many folks are part of this community today?
So it's a great question. I can tell you that we've got over 1 million visits per year to the website. And in worlds of millions and billions, that doesn't sound like a lot, but there's only, 400,000 of these procedures done a year? So it's a good part of the patient population and their care partners. And then we're very lucky that we have a social media following of about 522,000 people.
That's amazing. That's amazing. And Ms. Darian,
Yes.
you, I know, talked about the doctor that really helped you in getting to your procedure. How else, I mean, we heard about Dr. Bad Bedside Manner, but how else did your doctor help you and make you feel at ease and make you feel, you know, sort of optimistic for the future?
Well, when I first met the doctor, he came in, he shook my hand, introduced himself to me, told me who he was, asked me my name, I told him. He said, how old are you? I said, oh, I'm 80 years old. He said, what? I said, I'm 80. And he explained to me what was going on up here and what I needed. He said, you need surgery. I can't make you have it. You have to have it on your own. I said, okay. I said, do you have to open my chest back up? He said, no. I said, well, let's get it going. Because with the quadruple heart surgery I had, my chest was just wide open, and I was still sore. So when he said he didn't have to open me back up, I said, let's get to it. And I guess within 2 or 3 days, maybe after the visit and everything, all the tests was done. He said, are you ready? I said, yeah, I'm ready. So when the nurse prepared me for the surgery, he came in. He said, did it give you something for pain? I said, yes. He said, now, I'm not going to knock you completely out. You're going to feel something. I said, what? He said, you're going to feel something. He said, and if it hurt real bad, I want you to frown, and I'll give you something to ease the pain. I'm sitting up there, a big old machine with my name. I said, is that me? He said, yeah, that's you. Put me on that cold table. I said, ooh, it's coming. I said, give me a blanket. He said, no. He said, you got to lie very still. And he explained to me exactly what he was going to do and how I was going to feel. I'm laying there thinking, what on earth is he going to do? So he had to get permission from the cancer doctor. If he needed to insert anything in his arm, he could, because I'm a 24-year cancer survivor also. And I don't have anything done over here, but he had to get permission from him. So I'm laying up there on the table. He said, okay, I'm ready. He said, I can't guarantee you anything. He said, but I'm going to do my best. Whatever it takes, I'm going to do my best. So he was the last person I talked to before the surgery. And when I woke up, he was the first somebody I saw. He said, the surgery went well. All you got to do is take care of yourself now. I said, okay. But when they took me to recovery, whew, it was cold in there and I was hungry. He said, well, you can't have anything to eat. So they brought me a graham cracker, about that big, and a half a sip of water. So after that, I laid there. She said, well, the doctor said you're going to have to spend the night. I said, oh, no, I can't spend the night. My 2 daughters are here with me. And they couldn't take me to the hospital. It was full. So I had to stay over where they did the surgery at by myself. I begged for water all night. I begged for food. That's all they gave me. The next morning when he came in, he said, you ready to go? I said, I'm ready to go right now. I don't want no breakfast. I get some when I get home. And I got out of there and I came home. Well, before I came home, one of the technicians came in and gave me a heart monitor to wear for 30 days. I said, I can't operate this. She said, well, you're going to have to, or you can't go home. I said, okay, I'm going to operate it then. So after that, she put the monitor on me, showed me how to do it, how to change it. She said, you can even take a shower with it on. Okay. I get home. I put the thing down, get up and leave it in one room, and I go in the next one. It go beep, 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 beep. I'm too far from it, so I had to come back and get it. But other than that, thank God for Medtronics and Dr. Ahmed. I'm here today.
Yes, absolutely. We hear all the time that women, well, patients, our lovely gentleman on the panel, patients need to advocate for themselves. We hear that all the time, every day, all the time. And your therapist sort of said that to you in a way, right? Mm-hmm. Why don't you do something? Mm-hmm. But in the early days of trying to set this thing up, you had a lot of people say no to you. And now the results that you talked about speak to how successful you were. So how did you kind of frame this challenge for yourself? You didn't have to do it, but something inside you compelled you to do it and sort of take this challenge on.
Yeah, so it's a great question. I think when you become passionate about something, you kind of forget the why. Sometimes you just go. You just go to help people. And I've always I wanted to be a doctor for a point in my life. I took the MCAT. I did horrible. So this was an opportunity for me to do something. And you're right, I find that failure isn't a bad thing. And when this project started, all I did was fail. I mean, we didn't have any support from any company for 6-7 years.
Wow.
And now it's the greatest blessing.
Yeah.
Next to my wife, my son, and our dog Bodhi, that 24 hours a day, right now, we're educating people, we're empowering them, we're positioning so they can talk to Dr. Moran, so they can talk to any doctor and feel like they have a right and a voice in that conversation. And for me, that is why I do this. It's being able to empower people in a way that I didn't get to experience.
Yeah.
I was disempowered.
Well, it's interesting, this idea of advocating, because, when we think about the patient's experience, we're talking about their most vulnerable, often their lowest moment, their lowest point, energy-wise, motivation-wise, but also we are then asking them in that single moment to be their best selves and to have the executive function necessary to advocate and say no or disagree with a doctor, right? I think we just, I want to sort of put that back to you all to think about when we say advocate for yourself, be empowered, challenge the doctor. I say a lot, fire your doctor if you need to, find another one. But we're asking a lot of patients. So this patient dilemma, I think, is something that we just need to really be mindful of, because it's really easy to kind of say, job done. I've told them to empower themselves and advocate for themselves. So, we've ticked that box. So anyway, it's a really important aspect of our experience that sometimes we can own. We're ready and we're in that space to do it. But to ask for that consistently, I think, is, keeps us in this bind. So in our last minute, our last few moments together, I want to turn into to be a little bit more optimistic. Ms. Darian, what are you most excited about in life?
It's unexplainable. I got my life back. I go where I want to go. I do what I want to do. I don't have to wait on nobody to do nothing for me. I'm 99.9% myself. And am I happy? Yes. I wouldn't take nothing for my life back.
Wonderful.
I was just down.
Wonderful. About you, Adam, what are you excited about?
Yeah, for me, I wish, to answer your question, I wish I had this massive mirror and I could just put it up and you could all see yourselves, right? Because the conversation is happening right now. And I would invite you, I would try to enroll you in this cause of driving awareness, driving education, driving empowerment, driving activation. Getting people doing things that could ultimately lead to what? Treatment, right? And so I am so excited to come here from Los Angeles and be with you today. I'm so thankful that these incredible organizations like Medtronic are putting together these minimally invasive devices like Evolute that you didn't have to have that open heart surgery again, right? That first one was a doozy, yeah?
It was.
And so, yeah, I'm just overall very hopeful.
Awesome, awesome. Well, look, we have come a long way from the 1960s when the American Heart Association had a conference entitled, are you ready? How can I help my husband cope with his heart disease? This is a very different conversation today, ladies. Jaws, I know, lift up your jaws. I see the look all around. What gets me excited is that Ms. Darian and Adam and I are sharing the stage with clinicians who are just as passionate about this work as we are. There is an African proverb that I always like to end with, which is, if you want to go fast, go alone. If you want to go far, go together. Let's all go together so that we can go far. Thank you.
Thank you all for coming. Yeah. Thank you.
Thank you so much, Selena, Adam, Darian. You guys are so inspiring. Another round of applause. You know, you showed us candidly, you know, the impact of disparities in our healthcare system, but also how important that patient-doctor collaboration is and how much it really saves lives. Really incredible talk. Today, we also learned the importance of believing women, which leads to quicker diagnosis and better patient outcomes, how adjusting patient criteria can better center women in clinical trials and provide concrete data on how best to treat their unique needs. I see that not everyone has a red bag, but on your way out, grab a red bag. There's a card in there, take it out. This is gonna outline how you can take steps today to make a difference. We hope you will continue the conversation long after you leave here. And the biggest takeaway is that progress is possible. And again, I wanna thank Medtronic. You guys are incredible partners. This is an amazing, informative, important program. I also want to thank Women as One and Women Heart for the work you do in advancing women's heart health. And of course, thank you all so much for spending this morning with us, a really incredible morning. Enjoy the rest of your day. Thank you. Thank you.